Hello, everyone. This is Chadi Alraies from Heart Trending. I'm really privileged today to come with Dr. Rajiv Gulati, who is a renowned interventional cardiologist. Dr. Rajiv Gulati is the chair of Division of Interventional Cardiology and the cath lab director and consultant cardiologist at the Mayo Clinic. He's a professor of medicine at Mayo Clinic, Rochester, Minnesota. His clinical interest is complex coronary intervention, CTO, peripheral intervention, and TAVR. His research interests include clinical outcome after PCI, acute coronary syndrome, vascular biology, and spontaneous coronary artery dissection. He has more than 200 peer-reviewed publications and serves on the editorial board of several journals. Dr. Rajiv Gulati, we asked him to talk about coronary dissection. This is a very unique area in the interventional cardiology and also very challenging in terms of we don't know too much about it and also how to manage it. So we couldn't find anybody better than Dr. Rajiv Gulati to speak about it. Dr. Gulati, thanks for being with us.
Oh, Chadi, thank you for the real nice introduction. Real pleasure to be here. And I was just remarking to Chadi before we started about how much energy he's had since he was a fellow. I think he just does more every year, every month. So congratulations on getting this program up and running. And it's a real pleasure to be here. I've titled this Dissection and Other Causes of MI in the Young, and I want to focus somewhat on the other causes because it's been really interesting as this dissection field has grown. There may be in some circumstances a risk of overdiagnosing dissection and missing opportunities to treat other diseases. And I'll try and share some cases and some insight on that as we move forward. Forgive me for being a bit candid and maybe provocative, and I hope, Chadi, we can interact and talk about some of these cases and opinions. So I don't personally have any disclosures that are relevant. So outline, we'll start by talking about Minoka. This is a term that provokes different emotions in people, but for those that don't know, it is myocardial infarction or heart attack with non-obstructed coronary arteries. So less than 50% stenosis on an angiogram. Someone has an MI, and that's the angiographic description. It can be termed Minoka. And then we'll talk about causes of MI in the young. I'll share a little bit of data, but mostly cases. And then if there's time, and only if there's time, we can talk about a new proposed mechanism of disease that has come about from clinical observations. So my first candid point is that Minoka, and we hear about it all the time, that there's really some good information out there, a lot of awareness, but it is a category and not a diagnosis. And my urging to the cardiac community is that we do our absolute utmost not to let a patient leave the hospital with a diagnosis of Minoka. It should leave us all with a sense of non-fulfillment if we leave a diagnosis of Minoka. And so I'll spend a short while just talking a little bit about that. So it's a category, not a diagnosis. We must strive for diagnosis, and the diagnosis begins in the cath lab. So you've been staring at that case for a few minutes, and I won't put anyone on the spot here, but this is a woman who had chest pain, troponin rise, a sort of a very typical acute coronary syndrome, and the initial feeling was this was Minoka. Right? This is an unobstructed coronary arteries, and I won't put anyone on the spot, but that was the wrong answer. The answer is this is spontaneous coronary artery dissection. But those of you who do angiograms can be easily fooled by saying, well, gosh, as we were, that this is an unobstructed coronary artery. It turns out that this is the abnormality. Very easy to miss, and I can even now, looking at Chadi, see skepticism in his eyes, quite rightly so. And so I magged it up and I've drawn some arrows, and we call this the thick thin sign. We made that up, but you'll see a little thick vessel of contrast, then thin, then thick, then thin, then thick. And this is quite commonly seen in spontaneous coronary artery dissection or intramural hematoma, that irregular in a very distal vessel. Easy to miss. And in fact, you might even say now, gosh, what's this guy talking about? It's just a typically distal tapered vessel. Well, if you look at the repeat angiogram at 1 month, now look at the side-by-side comparison. This is what the vessel should look like after healing. And it had healed at a month, and this is what it was. So you can see how easy this was to miss. So that, I think, is lesson number one, that we not need to scrutinize the distal vessel, and we need to be aware of the angiographic patterns in some sorts of SCAD. So the clues here are: number one, it affected the distal vessel; number two, the fat thin or the thick thin sign that I spoke about; three is that severe coronary artery tortuosity is a association with SCAD; and the fourth, sometimes a relook coronary angiogram, which is what we did here, really seal the deal. And the fifth is actually the patient had a cardiac MRI and there was an infralateral myocardial infarction. And it was the MRI that made us relook at the angiogram and actually figure out this was a SCAD lesion. So you can see how a few years ago we would have said this is Minoka, shrugged our shoulders, one of those things, but now we're calling it spontaneous dissection.
And Rajiv, I want to pause here for a second. This is very intriguing. So we have a lot of fellows on the call, general and interventional. Would this come on the board?
Oh yeah, totally. I think I would say probably a slightly less hidden example here, but I think absolutely a distal RPL, OM, diagonal, maybe even a big diagonal that suddenly tapers, then it does fat thin, then tapers out. Looks kind of ratty, but all the other
Yeah,
vessels look great. That will be a beautiful boards question. I think everyone should be
yeah.
able to get that. And the
The
STEM would
second one,
be patient with FMD. We know that's an association, and a young woman with
oh,
ACS. Yeah.
yeah. We know you do a lot of board questions, so that's really helpful. The second question comes also in the role of imaging. Like if I have this kind of suspicion for dissection, is it routinely you do MRI on these patients?
Oh, what a great question. I mean, that when we'll come to intravascular imaging a bit later on, but I think Minoka workup, sort of just summarizing, it should be number one, absolute pristine coronary angiogram. We'll come to that, as in technical, excellent. None of this trying to save on contrast, save on radiation, save on views. That just got to go out the window. Number one. Number two, if you genuinely think it's a Minoka, you don't see what's going on, I get another set of eyes. You call in a colleague, be amazed what a colleague can see that you can't. Number three,
Yeah,
my view is I would probably do an LV angiogram, honestly. If you haven't got great imaging with an echo, I think an LV angiogram is very useful. And if still there's nothing there and there's really nothing to do intravascular imaging of, then an MRI absolutely can seal the deal. It can do what we did here, which is focus your relook on the angiogram, or it might identify something else like, like a myocarditis, perimyocarditis.
excellent.
So there's a lot of interest and some really excellent work from Reynolds and colleagues on the East Coast about potentially raising, are we missing atherosclerotic mechanisms in these patients who come with Minoka? And here's just some cross-sectional OCT imaging, and you can see a nice example of plaque rupture here.
Fragmented.
Maybe this is plaque erosion, all these sort of nice little examples of OCT finding things that may not be apparent on the angiogram. And the question that sometimes comes, well, should we be doing routine OCT in three vessels to look for these sorts of atherosclerotic mechanisms? I'm going to take a skeptical view of that and just look at the phenomenal paper that the group did. 170 patients. About 14% of those that were screened did this. They all had OCT, and plaque disruption was visualized in 46%, which is kind of a lot, right? I mean, that's a good amount. And at first glance, you think, well, gosh, there's a ton of this out there. Maybe this is the cause. My skeptical view of this is we know that mild plaque and plaque disruption is happening all the time. On this webinar may be happening out there in the community. So we don't have a control group. Was this bystander mild plaque disease? I really think that's a genuine limitation of the study because we know this is a well-known entity. So from this, if the question comes up, well, should we be doing routine three-vessel OCT and SCAD? We could have a debate on this, and very well-respected colleagues will disagree, and I respect all their input. My view is that no, we shouldn't. We should go back to the question you asked, Chadi, and do a much better job with diagnostic angiography and non-intravascular imaging in many cases. And sure, OCT in some cases, but not routinely in Minoka.
Excellent.
So I'm going to let this angiogram play for the fellows, for you, and my goal of playing this angiogram is to provoke disappointment. There's nothing wrong with the AV quality on Zoom here. This is the quality of the angiogram that, and I hope that the angiographer is not online watching this. Like, I don't know who it was, but this is the trend. And I said I wanted to be candid. That this is a trend that has happened over the last few years. For French, very short cine runs, very limited.
Yeah.
Turn the acquisition rate down to 7.5 or 5 at 3. I don't know what it is. At least the catheter was engaged and at least it's selected, but sometimes we're seeing that. And the thinking behind this, I've got to minimize radiation exposure to the operator, and we do all of these things. And my sort of thinking is that is all well and good if you're doing a long complex intervention. I think it's a fantastic thing to do for CTO. But if the patient has come for a diagnostic coronary angiogram, they deserve the best possible diagnostic coronary angiogram. And all those strategies, in my view, should completely go out the window. And I will remind people that Dr. Judkins, Loma Linda, a long time ago, we all know Judkins, this is a JL4 catheter, said the biggest complication of diagnostic angiography is non-diagnostic angiography. And
Oh, yeah.
that is what is frequently happening with these efforts to minimize radiation and contrast. So my lesson to the fellows is that's all well and good, but if you're doing a diagnostic angiogram, do a darn good diagnostic angiogram. 6 French diagnostics from the radial. If you've got a 6 sheath in, why are we bothering with a 5 French? It just doesn't make sense to me. Selective angiography, 30 frames a second, I will often do in these cases, not 7.5. 15 is routine, but 30 even sometimes. Distal visualization, zoom in, not mag out. All of those things that everyone over the age of 55 remembers from the when they would train. It's how they would do angiography. I would just urge that. That's my thought. So this patient, if you closely look at the angiogram, and 3 centers, this patient had gone to 3 centers that all said Minopa, normal coronary arteries, by the way, completely unobstructed. But if you relook, you see this was an occlusion in the distal
Yeah.
vessel,
Abrupt.
apical LAD occlusion, right? Abrupt cutoff. This is the signature. And here's my lesson. This is not spontaneous dissection. It would be easy to say young female with an ACS is SCAD, but something you can take to the bank. There's very few black and white things in cardiology. I tell you, a black and white thing is if you have an embolic, if you have a thrombotic filling defect, it's not SCAD. Intraluminal thrombus and SCAD do not go together. So you see an abrupt, this is an occlusion. That's where the LAD should run. I've drawn in that dotted line. We all the fellows remember that moustache at the end of the apical LAD. This is an abrupt occlusion. And knowing that prompted the search for an embolic source. And we see here on the, I'm not an echo guy, but this is definitely abnormal on this aortic valve. And I'll play the movie here. We see this lesion going from the LVOT out to the aortic root from the aortic valve, very mobile lesion on the aortic valve. This is either a papillary fibroelastoma, be a typical appearance for that, or, and the patient had some other comorbidities, this could be non-bacterial thrombotic endocarditis, but clearly is the most likely embolic source. And our treatment, we're still early here, is to anticoagulate her for 3 months and see if that lesion goes away, in which case the diagnosis was NBTE. If it's still there, it'll be fibroelastoma, and we will refer for excision and cardiac surgery. So really change this patient's management completely, right? Maybe prevention of a stroke, maybe prevention of an MI, all by a high quality angiogram, all could have been risked by a non-high quality angiogram. Just some other examples of embolic MI for the fellows. The one I've shown you is on the left, the distal cutoff. We've spoken about the diagnoses. The more common one is the filling defects in this middle one over here and multiple distal cutoffs. This patient was young, also called SCAD. This is not SCAD, filling defects. She had a DVT history, had a PFO, and almost certainly this was paradoxic embolus in the coronary arteries. This was a sort of much more of a rare zebra kind of case. The diagnosis we knew before she came into the room because of an amazing history of endocarditis building over 6 weeks and then a STEMI. And this was a vegetation that had embolized the aortic valve and gram-positive cocci on the aspirate histology. So that's just an embolic example. It's a rare one. Yeah.
Very interesting. One thing comes to mind also. with the quality of the coronary angiogram, I think some people don't understand that there is a, I'm not sure if it's happening also in Minnesota, but in Michigan, we have a peer-to-peer kind of quality assurance where we review other centers and they review our angiogram quality to make sure that this is diagnostic and we're making the right decision as a part of BMC 2 square. So
Wow.
people and cardiologists get scored for the quality, not just for the PCI, if they use IVUS or not, also for the quality diagnostic um, uh, evaluation of the angiogram itself. And they are talking down the line that's going to be bundled up into a properly scoring of the center, and every patient will be data will be available publicly for this patient to come and do these angiograms at this center.
That's amazing. I had no idea.
Yeah.
I'm sure there's some politics going on behind that, but that's just absolutely fascinating. And we don't have that in Minnesota, um, but it's really interesting. Gosh, I'm keen to hear how that goes. I hope hope the thrust behind it is a good one. It sounds like it could be, and it could be to patients' benefit with improved quality.
Yeah.
So that's really interesting. Wow. So this back to Minoka and what we started with, is this misclassification or misdiagnosis is it a problem? And I said I'd show you some data. This is data that's still in ready to be submitted. But I showed you those cases, and there's other cases too. How much of a problem is this? So just some early insight into a study that we're doing here in Rochester. And I want to give shout out to my interventional colleague, Claire Raphael, who started this project as a fellow, and she's now on staff. And just she's been on staff for a little while now, but it just shows how long it's taken to get this data together. So very briefly, we live in Olmsted County. It's a bit like Framing, and we're lucky. So since the 60s, we've had follow-up of every patient who's a resident in Olmsted County. It's 130,000 or so. So we can look at community-based studies and population and epidemiology in a very nice way. And so we looked at over 15 years, so 2003 to 2016, every event with a troponin of 0.01 or more, and classified all of these events, very detailed look at all of the medical records and angiograms. And that's what's taken several years to do, and try to figure out what is the true epidemiology of myocardial infarction in patients who are 65 or less. So we classified it into athero MI. So there's about 1,450 of MIs, athero, about that many, non-athero, supply-demand mismatch, your typical type 2, and the non-atheros we divided into the true cause. This is based on Claire Raphael and myself, and then David Holmes as the adjudicator looking at these angiograms, and also the MI mimics like Takasubo and myocarditis. This is patients who are under 65. I don't want to go, this we'll have more as the paper gets published, but the Minoka side of things, only 2.5% of MIs or MI mimics turn out to be Minoka if you scrutinize the patient. So it's less than, many of the observational registries will tell us it's much more than that. But if you really drill it down, it's actually not as common as we may have advertised in the past. What's interesting and pertinent for our talk today, Chadi, is that the index diagnosis, that is the diagnosis that was made mostly at Mayo Clinic when patients came in the early years, turned out to be these Minokas. About a third of them, when we re-scrutinized with our modern eyes and our modern knowledge of these diseases like SCAD, about a third of them were missed by us, me and my colleagues back in the day. And now re-looking, 3/4 of the misdiagnoses were SCAD. So when we index diagnosis and final classification, we see the direction of change. And this is just a side note showing that we have learned over time and angiographic patterns. And I think if you scrutinize, you can make a diagnosis. So moving on, this is another case of a 39-year-old woman with a non-STEMI with a single risk factor I mentioned there, and the white arrow shows a lesion, hazy lesion in the proximal LAD. And again, I won't. I'll ask maybe the audience just to think about what the diagnosis might be. If I hadn't shown the angiogram and just gave you the stem, a 39-year-old woman, only hypertension with a non-STEMI, we'd all be jumping around and say this is SCAD, right? I mean, that's what we think nowadays. Well,
Right.
she was treated conservatively for SCAD, and you see I put that in quotation marks, and she did terribly. She had unstable chest pain for the next 4 weeks. And this is, I think, the repeat angiogram. It looks exactly the same, right? SCAD doesn't do that. SCAD is highly dynamic, and we would see it looking different even a day or two later. 4 weeks later, it's not the same. This is the repeat angiogram. Looks the same. So intravascular imaging, this is one of those cases where it would have been the perfect opportunity to do this. And this is good old-fashioned atherothrombotic disease, completely classic atherosclerosis. You put in a stent and the patient feels magically better, and we reduce her risk of recurrent MI and death. So overthinking, 39, overthinking because of the 39-year-old woman with only hypertension and therefore it's SCAD has led to the wrong diagnosis. Fortunately, a month later, with the situation was remedied. But the lesson here is, go ahead. Yeah.
But one thing from the interventional standpoint is we say, oh, SCAD, don't touch it, don't worry, you're going to propagate the dissection, right? Especially if you're thinking that dissection, but imaging definitely play a role. So what's your take about wiring such lesion, especially if you have high suspicion for SCAD?
I think well, it's a great question, and it does come up. I think as a general observation, first of all, we underutilize SCAD in the right, underutilize intravascular imaging in the right circumstances. If you have an interval dissection flap already, or if it's a very distal lesion down a tortuous vessel, I think put those away. You don't need to do imaging for that. We have other things. You either make the angiographic diagnosis, or we can relook or do CTs. All of that we can talk about. It's these cases where you don't have an interval dissection flap, where you have a proximal or mid lesion. That would be super easy to put a catheter in here. Chadi, you're a very experienced interventionist. Looking at this, that it is safe. You can do this safely. These are the lesions where we know it'll make a difference. This is the perfect opportunity to do intravascular imaging. And I think if you just select those cases, the risk of causing a complication is minimal. And if you're super worried about injecting contrast, then just do good quality IVUS.
But based on the first angiogram, really, I wouldn't sleep good at night leaving it alone without IVUS. We don't have OCT, but at least with IVUS.
Exactly right. So the lesson is to beware overdiagnosing SCAD in young women with ACS here. And if I gave you this story, 32 and pregnant, we're all thinking SCAD, right? But she had a thromboembolus. This was from non-bacterial thrombotic endocarditis, and she got better with heparinization. This is another one, 33, pregnant, ACS, diabetes was a clue, and this is atherosclerosis. She was treated as SCAD throughout her pregnancy. I mean, she did fine, I will say. And after delivery, she came back with angina, same lesion, and was stented. But another case of misdiagnosis. And so my lessons for the fellows, I think, the angiographic observations and lessons, we've spoken intraluminal thrombosis, not SCAD. If you have an isolated proximal LAD lesion that's hazy and irregular, that looks like athero, basically, plus any risk factor, I would favor atherosclerosis as a diagnosis there. We know that atherosclerosis has a propensity for proximal LAD in isolation, so really think about it. And young women can get atherosclerosis. And as we discussed, these are amazingly good, these lesion scenarios for intravascular imaging. So these were all non-SCAD, but misdiagnosed. This is SCAD. All right, we see a diffuse narrowing from the left main going down to the middle AD, then it plumping up over here. Again, this was somewhat ambiguous. To me, it looks more SCAD-ish, right? And you too, Chadi, I'm sure would say that, but it's still not certain.
Absolutely.
There's no interval dissection flap. Again, smooth, but a perfect opportunity to get it right. And I think IVUS would have been fine, OCT, and just for the images, for the interventional, you don't need to do a full OCT run. You only need to capture one frame. So even like 3 or 5 cc's of contrast will make a diagnosis. We just need this frame, right? We don't need to see the whole lesion. This is the SCAD. We see here a lumen that is normal, no plaque, and this here is bleeding or hematoma in the vessel media causing a compressive narrowing. So this is compressed from intramural hematoma. This is of course, an autopsy of a left main, and we see saying the lumen is free of plaque, but is compressed by this bleed in the outer third of the media. So this bleed is this bleed. In this case, it was fatal here. A few points on SCAD, just for the audience. It's a non-atherosclerotic condition. Women mean age of 50, pregnancy associated in a small number of patients, typically the first 1 week in the postpartum, but it can happen in trimester 3 as well, rarely in trimester 1 and 2. And the phenotype is low athero risk. We see fibromuscular dysplasia of the non-coronary vessels in about half, a little over half, and coronary artery tortuosity in a similar number. Side note here, coronary artery tortuosity is very strongly associated with non-coronary FMD. That was just a surprising observation we made. And it suggests to me that maybe coronary artery tortuosity is a form fruit of FMD. Here's the very first case that made the diagnosis or the link between FMD and SCAD. This is a thank you to the femoral operator that did this. We were looking at these back in 2011, and we saw FMD in several SCAD cases, and then it twigged that there was an association. And here is Mac Alid, who was a fellow then, is now a very well-recognized structural interventionalist. He put that tortuosity findings together and associated with FMD and SCAD over here. So from principles, to treatment, which I think is really important, and we all need to know about it. And I just want to throw out some pathophysiologic principles that really help us figure out treatment. For the first is that the term dissection is misleading. If I say dissection, we all start thinking about aortic dissection, things flapping in the breeze, right? But most of the time in SCAD, about 2/3 of SCAD, there's no intimal dissection flap. It is just this compressive bleed. Here's an intermedial flap in this patient, nice little flap here, but most patients are just like this. So intramural hematoma predominates. Observation 2 is that conservative therapy, and you alluded to this earlier on Chadi, the reason why conservative therapy has become a really important part of therapy is twofold. Number one, because PCI carries with it risk, and we'll come to that. But number two, in many cases, if you leave these alone, they will heal over time. We'll come to that. But that's late healing. We'll come to that. And the third is that understanding these principles can help refine any techniques that we might use for PCI. So here is why it's just an amazing example of natural healing of SCAD. Patient on the left main, dissection, really, really ugly. She had very appropriately bypass grafting. This is 15 years ago. A year later, I don't know why, but she came back for another angiogram. I think it was atypical presentation. The lemur had occluded, the vein to an OM had stayed open, but the left main had just healed. Isn't that just amazing? I mean, we ever just imagine how that heals? And this is just a great example of the late natural history of SCAD can be healing. So late healing, and it supports this idea that conservative therapy is the way to go. You might imagine, wow, what if she hadn't gone to surgery? Could she have done okay?
And that's why the lima went down.
That's why the lima went down. You got it, because of competitive flow. But let's just keep that, let's file that for one moment and look at this case here of a woman with dissection down in the mid to distal LAD. Here's the bleed, TIMI 3 flow, and 2 days later, this is the baseline angiogram. You see here, nice brisk flow in the LAD, managed conservatively. 2 days later, complete occlusion of the vessel. And we can look at that here. We can just compare side by side, baseline and at day 2. And if you look carefully, you can see how this arrow here, look upstream, how even this has become narrowed. So this is hematoma extension, right? It shows it extends downstream with compression, occlusion, and extends upstream. And it just shows how dynamic SCAD is in those early days. That's the lesson over here, that SCAD is dynamic. Here's another case, and just remember that left main that I asked you to file. Now with that filing, here's a SCAD lesion over here. She was managed conservatively, and 4 days later had mild pain and near complete occlusion of the left main. And she did great. She had bypass surgery, but it didn't just heal. It's dynamic and evolved. And that's 2 examples. But here are some data. And this is from our group a few years ago now, where we looked at 240 patients who were managed conservatively. And it turns out that 15% of them had that adverse extension in the first few days. So 1 in 6, 1 in 7 risk of something bad happening with conservative therapy. This is the time course of when things deteriorated. So most of the patients extended on day 1 if they were going to extend, so 15%. Some in the first few days, then the risk tends to burn out. But this is the reason why we really push for, if we're going to manage conservatively, you keep them in hospital to monitor for the risk of conservative therapy. If we want to be clever and further refine the risk, those who had the highest risk of extension were intramural hematoma in isolation, so the absence of a flap was protective, and then high burden of SCAD, so multivessels or long lesions. And this is the basis of our recommendation now in the guidelines for 3 to 5 day hospitalization. And that can be really hard, right? You have young women with a new baby or someone who's itching to go home and feeling great. It can be hard, but
Correct.
we certainly, it's our practice over here to do this strategy.
So what would be the time where during that time period in the hospital you'll bring this patient back to the lab? What are the triggers?
Yeah, what a great question. We were number one, not routinely. We don't see any value in routine relooking. It won't change what you do. So of course, the main driver is going to be recurrent chest pain. Now you have to be mindful that SCAD in itself can be painful. So that dissection, just the wall can be painful. So pain may continue. But the main driver in this study and even beyond in practice is recurrent chest pain. So classically, the patient who settles down then has another chest pain, whether there's associated ST change or not, that will most likely drive a relook angiogram. And I think that's appropriate.
During that time, when this
Yeah, go ahead.
patient comes to you,
Yeah.
what is your regimen for this patient? I'm assuming when there's troponin, there's no elevation. Maybe the ER will start him on aspirin and heparin. Would you recommend any other initiation for any other medication?
Yeah, in fact, that you're perfect introduction to my next slide, and we'll come on to what we do for conservative management of SCAD. But just made me, your comment made me think about what would be the trigger to relook, and we spoke about that. But the important thing is that you manage someone conservatively. That doesn't mean conservative forever, and this is a risk. So, oh no, SCAD conservatively, no need to relook, but you do need to relook if they're having a STEMI. They can settle down and they can occlude. And there is a risk of someone saying, well, no, SCAD is conservative, we stop. No, if you go back and they've occluded, you need to open that vessel up and abort their infarct. So that's the whole
Yeah,
point of hospitalization, is to say there's a chance we may need to take you back and do an intervention.
right,
Yeah.
right. That makes sense.
So your question, because I've tried to be cute here, and it's not very cute, but A, B, C, D, E, F is our recommendation, and recognize that some of this is made up based on clever thinking, and some has some weak observational data. So we give aspirin alone as a single antiplatelet agent, and I'll say there is a trial going on in Europe led by Fernando Alfonso in Spain, looking at antiplatelet therapy in SCAD. Before you say it, I know you're going to say it, so I'm going to say before you, is you can make a great case for no antiplatelet therapy, right? This is intramural hematoma. Why are we giving blood thinners? It's really hard to hold back, right? You can imagine how hard it is for us to say, let's give no aspirin in an MI. So this is why we have settled for now on aspirin alone. But I think if there's willingness to go with a no antiplatelet investigational approach, I think that will be something that we talked about. Dr. Saw in Vancouver had a really nice study from her large registry that a few years ago now, oh gosh, 9 years ago, showing that beta blockers were associated with a low risk of recurrence. And we've adopted this approach. So we strongly recommend beta blockers. It's observational, it's retrospective, but it kind of makes sense, and it's the best that we have. So we beta block and beta block early. We usually avoid a statin if the cholesterol is pristine at baseline. Multiple reasons. One, it's non-atherosclerotic condition. And number two, we had some, again, this is a long time ago now, and the numbers were smaller, but our observational study suggested that statins were associated with a higher risk of recurrence. This could be confounding. It could be just selection bias here. But because we haven't shown benefit, and because it's non-atherosclerosis, we don't give a statin if the lipids are normal. If the lipids are abnormal, we give a statin. Deferred dismissal, we've spoken about 3 to 5 days. Early cardiac rehab, these are young women who have had their lives blown away by having an MI, and now it's really important that they get back to lifestyle quickly. So cardiac rehab is great. Currently, we still do FMD screening in the outpatients with a CT scan neck to pelvis. That's a whole separate discussion. Right now, we can't put our hand on our hearts and say it changes their management or gives you real good information that definitely makes a difference, but it may do as we gather more, as we learn more over time.
Question coming from the audience. Any
Yeah.
role for short-term dual antiplatelet therapy?
Great question. And I think that will be answered by Fernando Alfonso's study, I hope. My argument is a biologic one, and I would say we don't do that. Uh, for the reasons that I'm happy to expand on. One, it's an intramural hematoma, it's bleeding. Number two is you never see intraluminal thrombus in SCAD. It just doesn't happen. And so given the theoretical risk of making it worse and given the no chance of getting intraluminal thrombus, why give any blood thinner? So it just harks back to the pathology and to the observations we've learned over time. So I would not give it. I wouldn't argue it when people do it all the time. I think if there's diagnostic ambiguity, totally, I would go with it. I think it's just not worth avoiding it. If you think it could be athero, plaque rupture, or intraluminal thrombus, just give it. But if it's a clear-cut SCAD, we don't do it. I'm open to data changing our mind down the line.
Another question coming from the audience, if you don't mind, Dr. Gulati.
Oh yeah,
Is
great. I
there
love it.
a role for CTA in the diagnosis and management of SCAD? Would that be sufficient instead of doing coronary angiogram?
What a fantastic question. And my short answer for index diagnosis is CTA is not sufficient in 2024 to make the diagnosis. My friend and colleague Marisha Tweet has published a number of cases and case series in this, showing how easy it is to miss SCAD on index CTA, and we continue to see that all the time. Now, I mean, people are trying to be very thoughtful and saying, well, I don't want to instrument the vessel. CT can make the diagnosis. Let's do it non-invasively. But outside of really, really specialist centers or people with special interest, it is very easy to miss SCAD on index CTA. And the reasons are, number one, you missed a distal lesion. And number two, it is very easy to call something motion artifact that is SCAD. And that we've seen those two explanations multiple times. So I would say you need an invasive angiogram to make the diagnosis. Don't delay it with a CTA. Now, CTA can be fantastic for follow-up. So increasingly, and Marisha, who I mentioned, has a study on this, to getting a CT at baseline and then another CT down the line to look at various things in follow-up. It can be great. It can be great if you really want to look for healing for diagnostic purposes and you had an initial large vessel lesion. CT can avoid you doing another coronary angiogram down the line. So I think in follow-up it can be fantastic, but index diagnosis is not there.
Staying on the angiogram as well, are there any feature on coronary angiogram that would raise the suspicion for FMD?
Oh, what a brilliant question. And all I will say is the tortuosity is associated with the non-coronary FMD, but nobody knows what coronary FMD really looks like. What it doesn't look like is your typical beaded thing over here. In fact, when we did our study a long time ago, I think only 2 patients out of a lot had evidence of beading in the coronary artery. So I mean, we would have seen that by now, right? We've done the gazillions of these. So we don't see that typical thing that you see in the renals or the iliacs. Whether there is another kind of pattern on autopsy or OCT, that is an interesting area. And Jackie's published some of this, but I just don't think we have hard information to share saying this is your phenotype angiographically of FMD in the coronary arteries. Just the tortuosity is associated with it. Whether it means it's FMD in the coronaries, I don't know.
I love this
These are
question still
amazing
coming from
questions.
the audience. If you don't mind, keep going with those.
Yeah, great.
The other question is, if we compare this aortic dissection to aortic dissection management, is there any role for managing diastolic blood pressure with aortic dissection and controlling systolic less than 120?
Oh, these are just amazing questions, and of course we don't know. But I think if we just go back to the pathology with the aortic dissection, it's clearly in most cases it's intimal flap, hydraulic extension. It makes total sense to keep your pressures down. In spontaneous dissection, we think it's in most cases it starts in the media with a bleed and there's no intimal flap. So it's a different pathology. It's not like an intimal tear that it extends. It actually is an outside in process. It starts in the media and then it may evolve to actually a decompression from the media to burst into the lumen. So reverse an outside in phenomenon. So mechanistically, it doesn't follow the same pattern as aortic
Yeah.
dissection. But beta blockers, it makes sense, and we make them that to the end to use those to reduce maybe myocardial forces rather than coronary shear stress forces. So I don't think it's a shear stress condition in the coronaries, is basically what I'm saying.
I have one more
It's a great,
question from the
great
audience,
question.
and I would like
Yeah,
the audience to continue with this question, the Q&A
yeah.
box. Risk factors for recurrent SCAD. I think the question is, if somebody had a SCAD already, what are the chances of having it again?
No, that's a brilliant question, and let me answer that in a couple of ways. One is if you look at the registries, the retrospective and even the prospective registry, the risk of recurrence of a second event is probably 10, a little bit more than 10%. The problem with that is that the registries may be biased with patients who've already had a recurrent event. Right, so who gets entered into the registry? A little SCAD that goes away and never happens again, maybe we don't hear about that patient. But the patient with the recurrent event, maybe, now they're getting worried and they come and then they get into the registry. The registry may be sort of have more patients who've had recurrent events in them just by nature of a registry design. Prospective registries can help address this. Our community-based study that I shared with you at baseline, we part of that study will show a recurrence risk in SCAD, and bottom line is I think it's lower than we previously reported. In
Lower.
terms
Okay,
of
good.
risk for
Yes.
recurrence,
Yes. Yeah.
I will just give kind of shout out to Marisha Tweet who is looking at that with about a 1,600 patient population. So we'll have that information come through down the line. I think
Yes.
one thing that is a lower risk of recurrence is pregnancy associated SCAD. I think that's a low risk of recurrence. That's probably a different mechanism.
Yeah. So, is it okay for somebody with history of SCAD, a female, to get pregnant?
Yeah, what a great question. And I'm not sure I'm the best person to answer that. I know that, again, I get mentioning Marisha Tweet, a great friend and colleague, has looked at this and continues to look at this. We know the risk is high, but there's no need to avoid pregnancy. We don't counsel patients again. People want to have children, so we don't counsel against it. The harder
Yeah.
question is if someone has had a pregnancy associated SCAD, what is their risk of another event? And that's a real hard question. The initial data that was published, I think there was 14 patients we had, and one had another event during pregnancy. Don't hold me to that. I may
Yeah.
have got the numbers wrong. And so we were counseling against additional pregnancies initially. We have more numbers now. We may be able to modify that recommendation. And by the way, we can counsel as much as we want to do, but people will do what they want to do.
Yeah. So we have 3 more questions, but if you'd like to continue, Dr.
Oh,
Gulati,
I
and
don't
then
mind.
yeah,
These are amazing questions. Shall we move on and
genetic.
then?
Yeah, let's move on, and then we'll save some time to the end. But for the audience, please keep bringing these questions. We'll cover it at the end.
Love it. Now we can skip a little bit quickly through. I mean, some of this is more focused on the fellows and the interventionalists over here, and I'll skip through and just give a lesson here that this can be really hard. Look at this ambiguous LAD lesion, and look at this IVUS. And Chadi, you're a brilliant operator, but even the most brilliant operators will struggle to make a diagnosis. I have no idea
Yeah.
what this IVUS is showing. Right? It is the digital IVUS. Digital IVUS is not as good resolution as the rotational IVUS. And this is
Oh,
why
wow.
when you do this, you need to really scrutinize it. You need to
Wow.
get out of the lab,
You,
sit down, feet up, headphones on, and look at the imaging. Because if you grow a couple of
yes.
frames up and down,
Wow.
we can actually see the internal elastic lamina, which means this is intramural hematoma because the lesion is outside the internal elastic
Yeah.
lamina. Cannot tell on here,
Same
and you
patient,
can't tell in
same IVUS.
two
Yeah.
frames apart.
Wow.
One here, scroll 2 frames, and this is where you make the diagnosis. So this alone, You could say, I mean, it looks like plaque, right? I mean, it could be anything, but this
Yeah.
tells us this is intramural hematoma. So it's important, if you're going to use this IVUS, this digital one, you've got to be really, really thoughtful and scrutinizing.
Yeah.
But if you use this IVUS, this rotational one, it's much easier to see. That looks a lot like
Yes.
the OCT, right? We can see the interelastic
Yes.
lamina very
Yeah.
easily here. So if you got the luxury, I would choose one of these two over here. If you haven't, then just really be cautious and thoughtful and scrutinize frame by frame.
Yeah. Interesting.
I'm going to skip this one because this is very interventional. And I'll just go to this, if that's okay, Chadi. We spoke
Please go ahead.
about how we can make a link between the pathology and the treatment, and we said that SCAD is hematoma and not plaque. Hematoma can displace and extend like toothpaste if you instrument it. And an intimal tear, we know in SCAD, if it's present, it's not a thrombotic substrate. You and I have been told if you leave a dissection flap after a stent, that there's a risk of occlusion, so we can put another stent in, right? That's what we do. And that is true if the substrate is atherosclerosis. It is not true if the substrate is SCAD. You can leave an intimal dissection flap in SCAD and it will not develop acute thrombus. So it's a different disease. Therefore, balloon angioplasty alone can be a good option because your goal is to get flow. The goal is not to get a pristine stent-like result like we do. I am gonna, I'm going the wrong way. I knew I was doing something wrong. Let me just go forward. So as an example here, so this is a LAD that's occluded here. This was presented. This is an LAD that's been balloon angioplasty. And this is what ventricular fibrillation looks like in the cath lab.
No.
For those fellows that want to look at this, you see there's no contrast
Scary.
anything. You can see the ventricular fibrillation over here. Scary, right? And this is afterward, TIMI 3 flow, but a long intimal dissection flap. If this was atherosclerosis, you'd be unhappy. You'd be starting to tack it up with stents. In SCAD, you leave this alone. This is, don't, you put in stents, you run the risk of long-term complications. Leave this
Yeah.
alone. It will not reocclude. I mean, most likely not reocclude, and most likely the patient will do okay.
Technical question.
Yeah.
Cutting balloon or regular balloon?
Thank you. This is the next question. Should you use a regular balloon or a cutting balloon? There's been some vogue for using a cutting balloon which has got blades on it to try and slice into the intima and decompress that lumen, decompress that hematoma. My argument against this is that cutting balloons are great when you've got ugly atherosclerotic plaque and calcium and you want to slice through a lot. But look how thin the intima medial membrane is in SCAD. I mean, 250 microns, super thin. A regular balloon, so fragile, will fenestrate that. So my thought is, again, I may be going against the grain. My thought is low pressure balloon angioplasty alone. Why take a very big, bulky balloon down the tortuous things and risk disrupting the vessel? I don't think it's necessary. Now, there's several cases towards cutting balloon. I'm not going to argue with people who advocate for it, but I think a balloon alone is adequate.
Yeah.
Shall I show a risk, a complication of stenting here? So this is I've just selected this because there's multiple complications in the same patient. So this was the baseline lesion, high-grade LAD, intramural hematoma. There's actually also an intimal dissection flap here. So the diagnosis is SCAD. She had TIMI 3 flow at baseline, so I guess could have been left alone, but I won't argue. A stent strategy was chosen here, and you see a stent is being positioned in that proximal LAD lesion. So here's complication number one. The stent is now, so this stent looks fantastic, but look at the downstream. That hematoma, that toothpaste-like blood has now been pushed downstream, and we see how it's critical stenosis over here because of displacement of hematoma downstream. So that's complication number one. We know that can happen with SCAD. It doesn't happen with plaque. It happens with intramural hematoma. All right, so now we're feeling the pain here. So the next strategy here chosen was, well, I've got to put in a second stent down to that area. And it was noted that it was difficult to advance that stent through the first existing stent, and a guide extension was chosen. So this is a guide extension. This arrow was the first stent, the proximal end of the first stent. It's maybe hard to see, but that stent is no longer there. It has been squished here.
God.
So the stent has been squished by either the guide extension or the new stent down here. because this is
So
not
serious.
anchored in place, right? Yeah, it's longitudinally compressed. It's not anchored in the plaque. It's kind of not well secured, and that's what's happened over here. Okay, so severe stent longitudinal
Oh,
compression and distortion. Rescue the situation, other stents replaced. It looks a little ugly here, right, with all of that squish stents, but it's relined and the flow is good. I think I said there were 3 complications on this patient, and that's the second one. And the third complication was the worst, acute stent thrombosis, because of
oh
all of
my
that
God.
mishmash stuff. And occluded LAD, emergency coronary artery bypass grafting, required. Patient did okay, but 3 complications in one patient as a result of stents. Here's just a
That's
different. I've shown this at other meetings because it always just amazing to see how this stent is literally floating. You see how the stent here is literally bobbing around because
yeah.
months later that hematoma, undersized stent, because you see narrowed vessel hematoma, gets resorbed naturally, and the stent is now left just floating in the middle of the LAD here. It's an
Wow.
old picture, 2007, but just kind of an example. Another reason why stents can be issues, these vessels are tortuous. This patient had a long length of stenting in the LAD and had recurrent restenosis and stent fractures because of the tortuosity and hinge points as the vessel tried to reconfigure. This was a real challenging problem for the patient here. So it's why that, you got to be, stents are different in SCAD compared to atherosclerosis. So for the sort of summary of SCAD, mostly from a therapeutic standpoint, is that conservative therapy is appropriate because late healing is a norm, but there is that early dynamic risk that I think we spoke about. Hence, we
Yeah.
observe if you're going to do digital IVUS, you've got to scrutinize it. Balloon angioplasty can be a good option if the vessels are occluded. You don't need to worry about residual intimal dissection flap. Sense can work, but we've just seen a few of the risks. But I always caveat by saying there are no hard and fast rules. Whenever we think we've got it completely figured out, there'll be more information and more cases that make you question your initial thoughts on SCAD. So that's mostly on SCAD. I
Phenomenal.
said if you want to talk about new mechanisms, we can, but if there's other questions, I'm happy. However you want to do this, Chadi.
Yeah. Let's go over these questions, Dr. Gulati. Should
Yeah, let's
genetic
do it.
testing be performed for collagen vascular disease in spontaneous SCAD?
Yeah, what a great question. So we looked at this several years ago, and the rate of cardiovascular disease is very low indeed in SCAD. I don't remember the number, so we no longer routinely screen. It can be very expensive. Obviously, if there's other clues, obvious clues, then we may go down that genetic pathway, but it's not routine for us.
Okay. Does management change based on the type of SCAD, type 1, 2, or 3?
Oh, what a great question. Our at Mayo,
Maybe you
we
can go
don't.
over the types a little bit.
Yeah, so actually we don't use that terminology. It's not a critique at all, but we don't use that terminology because we didn't found it answer the question that was being asked here. Does it make a difference in your treatment? So what we prefer to do is to say intramural hematoma, intimal dissection flap, or both, because that is really dictates the natural history. So intramural hematoma in isolation, in other words, without a dissection flap, that's the one that has the higher risk of extending. So that's the patient that we will definitely observe in hospital with no questions at all. We'll observe them ideally for 5 days. So does that change management? Yes, it does. IMH in isolation, we'll observe for sure. If it's IMH and it's an occlusion, we may do fenestration with a balloon to treat that. So I guess that's it. That's what I see. If it's an intimal dissection flap, that is a lower risk of extending. Maybe we'll let that patient out sooner than the 5-day hospitalization. I
Question
guess
about
that's
the
the only way it
management.
changes. Yeah.
Yeah, about the intervention management. If we are pushed toward an invasive approach to SCAD, I think, like similar to the case you showed us with the STEMI zero flow, what would you recommend? POBA or cutting balloon or proximal and distal stenting to the SCAD?
Great
I
questions.
think to touch on it briefly.
Yeah, you bet. Great questions. First of all, important. Sometimes you do need to intervene in the SCAD, right? If you've got a vessel that's occluded, a mid vessel in the LAD that's occluded, and you've got to get this to stop the MI, right? We've got to do that. And it sounds crazy just saying it out loud, but there, sometimes there is this concern that patients are just treated conservatively. And I think my algorithm will be, if you can get it open with balloon angioplasty and TIMI 3 flow and it looks okay, I would stop at that stage. I wouldn't use cutting balloon because of the reasons we described. I think a balloon alone is adequate. This idea of sealing both ends works in theory if you think the problem is an intimal dissection flap at baseline with a hydraulic extension like an aorta. We don't think that's the problem. We don't think this is an intimal dissection flap that's causing the issue. So that doesn't make sense to do a sealing strategy. It does make sense in an aorta, but I don't think it makes sense in the coronary arteries.
This question I think we already touched on in terms of, but one of the questions I know the answer for, especially speaking to Rajiv Gulati, femoral versus radial approach for SCAD PCI.
Well, great question. And I would say whatever you choose, I would not avoid the radial artery in diagnostic studies for SCAD. Now, the person who asked the question may be very well clued up, maybe noted that way back. So there's a consensus statement, maybe radial was associated with a higher risk of iatrogenic dissection. I think that was back in the day when radial was less frequently done and was not done well. I think the key is, well, two keys. Number one, there is a higher risk of iatrogenic dissection, catheter-related dissection. These are very fragile vessels. But it's all about how well you align your catheter coaxially. So if you do a good job of thoughtful access and coax align with your vessels, it doesn't matter radial versus femoral.
Excellent. Dr. Gulati, this is one of the most insightful and detailed presentation I have personally attended.
Oh gosh.
With up to date. As you know, this space is diagnosis been there, but we are probing more into how to manage it and how to deal with the situation going forward. I would like to thank you for taking of your busy time to join us today on the Heart Trending webinar, and really for your thoughtful comments, and also for the viewers who really contributed phenomenal questions, and the audience. Thank you for joining us today.
Thank you again, Chadi. Real pleasure to be here. You're super generous, and just whoever asked those questions, the audience, just loved the questions. Really, really thoughtful, and
absolutely,
it's an exciting area. Thanks again, Chadi, for the opportunity to share some stuff with you.
Thank you. Thank you so much for your time. And again, stay tuned for next month. As we said, we come on the third Thursday of the month, April 18. We're coming to talk about the state of the art and management of outside cardiac arrest with Dr. Tim Henry. Again, registration link will be sent soon. Thank you all for joining us tonight. Dr. Gulati, thanks so much again for joining us. Dr. Gulati is a professor of medicine at Mayo Clinic, the School of Medicine. He's the chief of interventional cardiology division at Mayo Clinic, as well as phenomenal speaker. For all the fellows there, you have to attend his lecture at the Sky Fellows as well as at the ACC. Phenomenal speaker, as you have seen already, beautifully illustrated.
Thank you again. You're so kind. Thanks, Chadi.
Thank you.
Bye.
Bye-bye.